So I'm so glad Sakith put the words to what I was just going to say. I promise I will not spoil the case today, but will tell you that it features very quickly analyzing a patient who is hypertensive. And I think um, whenever you're faced with a clinical scenario that involves pretty impressive hypertension, I think medically we've all been trained and conditioned and even passed on to our patients the idea that a high blood pressure is something to worry a lot about, especially in an acutely ill patient. And so it's hard for our minds not to give that number and highlight it and bold it. And I think we really have to understand what its implications are. And so I think I will to hopefully make what is a complicated space um, because of iatrogenesis. Let me take you to a space that is actually identical, I think, but for some reason has been taught and passed on from generations to generations with much more clarity. And that's the other problem that the patient had, and that problem was hyperglycemia. So Shreya, I know you were there, and so I'm curious just to ask you a completely hypothetical question, unrelated to today's case, but we'll come back to it, which is next year when you're admitting patients and the ER calls you and says, I'm admitting this patient to you for hyperglycemia. I'm curious what thoughts would start to cross your mind just with that one word alone, hyperglycemia.
Uh, so the patient is solely admitted for hyperglycemia, am I right?
That's right.
So I would think about uh, acute complications of hyperglycemia, or maybe there is underlying uh, long-standing diabetes,
Mhm.
which was not maybe undiagnosed, or sometimes diabetes gets diagnosed by the complication. The patient presents with the complications like TK itself. I would think about that, and I would also think about like the patient who have been diagnosed with diabetes, or they have like absolutely almost 100% chance of CVA in their life. I mean, they may not present with the acute presentation later in the life, but the arteries are already getting damaged. So I would think about that. And I'm not sure where are you hinting at.
Oh, no, no, no. The beauty about these open-ended questions is there's no specific focused answer. It's just opening up a large landscape of things. And I think you opened up every door that should be opened. So I'll just reflect back with you. So Shreya, you made the leap that patients who are presenting to the hospital with acute hyperglycemia, the vast majority of them have diabetes. And I'll translate that to mean that the vast majority of people with acute hyperglycemia actually have acute on chronic. And so hold on to that thought. So you made that as a very likely, it's not 100%, but very high. So you're like, do they have underlying diabetes? That was excellent. And then your reflections seem to be in two different categories, which is what is the underlying reason that they have acute hyperglycemia? And then what are the complications of this? And you listed the complications in two categories. Acute, and the example you gave was DKA, and chronic, the example you gave was CVA or stroke. And I encourage all of you to fully adopt that model. Acute hyperglycemia, what's the underlying cause of the chronic hyperglycemia, and what's the underlying cause of the acute component to it? In terms of complication, what are the chronic complications of the chronic component of hyperglycemia? And what are the acute complications of that, of the hyperglycemia? So if you're imagining this problem, I hope you'll see the flow sheet that has cause and consequence, acute and chronic. So it was that was excellent, Shreya. Now we should try to do that same exercise with hypertension. And I will tell you that I made the argument that most people who are acutely hypertensive enough to be in the hospital often have a chronic component, and that bore out with our patient. So let's go under the causes category. And so, Jillian, maybe I can ask you, how do you think about the causes of chronic hypertension? What do you think?
I think the most common cause is primary hypertension, which I guess just means kind of idiopathic, like age-related, I don't know.
Okay.
And then I guess I think about other more like causes of secondary hypertension, or maybe lumped into primary could be like, now I guess we're thinking some causes of primary hypertension, so-called, are like hyperaldosteronism, but also like other things like pheochromocytoma, kidney issues, like renal vascular. I guess I'm thinking about all of the like weird things, not weird, but
Yeah. Yeah.
renal vascular disease, other kidney causes of hypertension, or just like extremes. I guess non-chronic would be like some kind of acute extreme stress.
Excellent. Excellent. So you had a really good schema for the chronic, and then it was hard and very tempting for you not to veer into the acute category. I think that temptation is a wise one because most of those patients are vulnerable to acute rises. But if we stick to the sort of chronic category, to continue the parallel with diabetes, you'll find yourself, especially with adults, that you have a default diagnosis. And if you're just literally have no resources to invest, you'll be like, diabetes in adult, that's type 2 diabetes. And you'll find that just like primary idiopathic hypertension, there's no definitive test to prove it. And it's a diagnosis that is a very good operating diagnosis unless you have something else. And you'll do the same thing with hypertension too, is you won't really think about it unless you have something else. And there's specific criteria for you to think about diabetes beyond type 2 diabetes in an older adult. And there's specific criteria for you to think beyond the primary hypertension and then start to delve onto the specific categories that you mentioned, Julie. That's excellent. Um, I know you were there, Manaswini, and I think we talked about it a little bit. I'm curious, now that we have Jillian's platform um, for chronic hypertension, I'm curious what thoughts you have about the things that cause acute hypertension.
I would think in terms of causes like endocrine, probably hyperthyroidism, a thyroid storm, or it could be a pheochromocytoma, or probably an adrenal adenoma acting up, or
Mhm.
it could be um, a hyper a dissection, vascular
Mhm.
causes like
Good.
dissection, and or yeah, probably if the patient is on cocaine,
Good. Good.
or um, and if he's on yeah, I see that Saket mentioned drug withdrawal on the chat
Right.
as well.
Right.
Mhm.
It's amazing, Manaswini, how effortless it was for you to list diagnoses, probably from reading and experience. And I think over time, my goal now in the next 2 minutes is to show you the parallels that you and Jillian actually are outlining with the secondary causes. So this is the part where I hope to take you on a journey of simplicity so that you can not have to rely on deep memory of individual cases or books, but to actually go back to simple principles. And the simple principle that I hope you'll agree with is that hypertension must be mediated by a specific substance. Now, that may be a little confusing, but hypertension is not a focal structural disease. It's not a large mass, or it's a diffuse problem affecting all blood vessels. And so if you just take a leap of faith to say that there's something causing these vessels to be clamped down, what is it? And the truth is, most of the time we don't know. And that's primary idiopathic hypertension. For some reason, these patients, we don't know what that substance is. And so what we try to do is we try to block some substances, the angiotensin, renal angiotensin pathway, as an example, or we try to remove their volume by having them waste salt. Um, but if you go back to what Jillian said, so let's use her example. She said renal artery stenosis, obstructive sleep apnea, and other ones as well. What do those things have in common with your list, which was pheochromocytoma, hyperthyroidism, so on and so forth? And I will tell you that the vast majority of patients with hypertension that is of a specific etiology has either a surge in catecholamines or a surge in aldosterone. And that's where Jillian's adrenal adenoma and your flare of adrenal adenoma come from. That's where the stress that Jillian mentioned merges with the pheochromocytoma that you mentioned. So in most people who have hypertension, they have a surge of catecholamine that can be a chronic surge or an acute one. Most people who have hypertension either have chronic hyperaldosteronism or an acute one. There is a very, very small number of people who have hypertension driven by an endocrine process that isn't those two molecules. And in those patients, they rarely just present with hypertension alone. They present with the other effects of thyroid hormone, or the other effects of growth hormone, or the other effects of parathyroid hormone. So for me, when I'm thinking about hypertension, I recognize in the vast majority of people, this thinking exercise is a futile one. It's a waste of time. You'll never find out what they have. But if you've learned your red flags to search for a secondary cause, including acuity, acute blood pressure, you realize what can do this? And there are two very blood pressure focused hormones, catecholamines and aldosterone. And there are a subset of other hormones that rise blood pressure but cause much more chaos. They cause your body to grow and literally to grow, or they cause you to have all sorts of other features like hyperthyroidism, or all sorts of other features like hyperparathyroidism. But if you were to list everything that you guys just said, most of them will be under a category of either catecholamine surge or aldosterone surge. Chronic catecholamine surges, obstructive sleep apnea, chronic hyperaldosteronism, Conn syndrome, Cushing syndrome, so on and so forth. And so if we were to apply that to the secondary causes that are chronic, you're asking yourself, why does this patient have chronic catecholamines, chronic hyperaldosteronism, or a chronic diffuse endocrinopathy? And in the acute category, why would somebody's catecholamines go up? Gosh, many reasons, so many reasons. And I'll just refer you to a whole series of Academy sessions on this topic called sympathetic excess. Why would somebody's aldosterone rise acutely? I think that's the thing that is maybe a little bit counterintuitive, but Manaswini mentioned it already, and I think it'll actually be a part of Sarah's future world. So I'm curious, Sarah, if you have a take on it, like why would somebody's aldosterone suddenly abruptly rise? What do you think?
Well, I think the one thing that we haven't talked about yet is in acute stroke, you have acute hypertension. So,
That
yeah.
nailed it. Yeah, acute cerebrorenal ischemia. So, not to imply that you have to have both ischemia to your brain or your kidney, but either ischemia to any of those two organs will trigger the renin-angiotensin aldosterone system. And the idea being that those organs are, whenever they're hypoperfused, they send massive red flags to the rest of the body to ramp it up. And so, if you're in the world of acute hypertension, you have to, for a brief moment, wonder, is what's driving this acute hypertension ischemia to the brain or ischemia to the kidneys? Of course, in the catecholamine category, there are other emergencies too. And for that, I'll refer you to the sympathetic toxicity spiel, but I'll remind you that any emergency can present with sympathetic excess. And the idea being that if it's a true emergency, it means it's sudden in onset. And whenever something is sudden in onset, the body's alarm system goes bonkers. So you name an emergency, if the patient perceives it as a threat to their existence, especially when they had no time or warning to adapt to it, you will get acutely, you will have an acute sympathetic storm. And in some emergencies, that the sympathetic storm is short-lived. because the actual emergency now takes over and the body's compensatory mechanisms or warning systems are not sufficient to keep you hypertensive while you've developed the rigors from gram-negative rod bacteremia, because that'll only happen for the few minutes or hours. But then the actual gram-negative rod bacteremia will kick in. And you can name that for any kind of emergency. A ruptured AAA, boom, blood pressure skyrockets, but maybe for 5 seconds until you hemorrhage out. And you can apply that to any emergency. And so it is true that when somebody's acutely hypertensive, acutely so, what you could be sitting on is literally anything that's sudden in onset. And the good news is there's a whole reflection and schema on what things are sudden in onset, or that there is cerebrorenal ischemia. And I think this is why people really, really worry about acute hypertension, because you're literally dealing with all the emergencies that are under the sudden onset umbrella, and or you're dealing with acute cerebrorenal ischemia. So the range of possibilities is enormous. But here's the good news. If we're talking about a life-threatening illness, either under the catecholamine category or under the aldosterone category, life-threatening illnesses are not subtle. And of course, early in your training, you're going to be spending a lot of time wondering whether you're missing something. But the good news is when things are really, really risky to the patient, they're harder and harder to miss. And so you walk into a patient's room who's acutely hypertensive, and you're dealing with a ruptured AAA or a fracture or a gram-negative rod sepsis. It's not subtle. What's much, much, much more common is the patient has acute hypertension but looks fantastic, looks really well. And that's the dilemma that often now we sit there and wonder, well, I'm talking to this patient and they're talking to me, so I doubt that they have cerebral ischemia. This patient has no fatigue, malaise, changes in their urine, and sure, I might get a creatinine, but I'm not worried about them having kidney disease. Kidney disease usually shows up really poor symptoms. And they don't have sudden onset symptoms. They're here for a variety of reasons, and their blood pressure is high. And I think that's where we start to pivot to the complications of hypertension. We're like, okay, you're here, you're not too sick, so I don't think there's something acute and serious driving your hypertension, but now what? Now I'm really worried that the blood pressure is in front of me and you're going to suffer some serious consequences. So if we're going to keep the analogy going, the consequences for hyperglycemia are divided into acute and chronic. Both acute and chronic are actually vascular complications. The chronic complications that Tria outlined are essentially arteries get narrowed. And the acute complication mostly is that volume gets depleted and you become dehydrated. So let's try to build it out for hypertension. And Magnus, maybe I can ask you, what is your thinking about the chronic complications of hypertension?
Yeah, so in terms of chronic complications, I think of kidney disease, starting with albuminemia, microalbuminemia.
Beautiful.
Also think of heart disease, so you can get LVH, like we saw in the patient, ultimately develop heart failure. Yeah, atherosclerosis, I think also. Yeah.
Excellent. Yeah, I think I'm going to try to pull up a picture for you all. I think that, again, it's sort of the power of the analogy here, I think. Sorry, let me see if I can, yeah. Oh, yeah, I'll pull it up later, actually. It's a little bit too complicated for now. But yeah, I think you're fundamentally right. What happens with chronic hypertension is blood vessels, most commonly blood vessels don't like it. And it usually actually is the small blood vessels. And hypertension is a small contributor to atherosclerosis. It's a much larger contributor to arteriosclerosis. And those two terms are actually very nebulous and often merged together. But to illustrate that nuance, maybe Sarah, I'm sorry to ask you two questions in one session, but I think this is a very neuro-relevant question, which is if you're trying to implicate somebody with hypertension and getting brain problems, if you had to sort of pick a classic cerebral event that happens because of hypertension, where would that event be?
Yeah, lacunar strokes are
Yeah.
kind of your chronic small vessel stroke, like lacunar thalamic.
Yeah.
Yeah.
Yeah, excellent, excellent. It's really those tiny vessels that get a very different pathophysiological entity called arteriolosclerosis. And hold that thought in mind because we're going to talk about it on Saturday for a case you'll never ever forget, I promise. So even though it's tempting to say hypertension contributes to atherosclerosis, which is a disease of the small and medium vessels, most of the time the damage from hypertension is those tiny little blood vessels. And you guys already know that because you know that you can see those blood vessels in the patient's eye, tiny little blood vessels. And an ophthalmologist can tell you if somebody's had chronic untreated hypertension. And you can see those tiny blood vessels bleed into the urine, which you then look at. Tiny, tiny little blood vessels. So it's usually a small vessel disease. But the pressure, chronic pressure everywhere ultimately affects the heart. So the major sort of macro phenomenon is the heart itself causing LVH. Awesome. So Simi, I'm curious. So now we're under hypertension and acute. So what do you worry about as acute complications of hypertension? What do you think?
Well, I would think about subarachnoid hemorrhage because sometimes patients with hypertension suffer that, and mainly vessel rupture due to high pressure. That is what comes to mind.
And I think that's exactly what you've been taught. I have no doubts about it. But I'd love to disentangle that with you, okay? So you might keep your unmute on for a little while. We'll just go back and forth, okay? So let's talk it through. Somebody's blood pressure acutely increases and their blood vessel in their brain bursts, causing a subarachnoid hemorrhage. Do you think that the exact blood vessel that burst, was that healthy before it burst or was it unhealthy?
Probably it must be unhealthy because maybe we are going to the concept of vulnerability here, that the patient was already vulnerable and then the trigger of hypertension maybe caused the rupture.
Exactly right. Exactly right. And so now, this is not a space that most people know very well. So I'll just tell you that most subarachnoid hemorrhage is from berry aneurysms. Most atraumatic, sorry, is from berry aneurysms and AVMs. Both those conditions actually have a rupture rate, if you look at the literature, that is independent of a patient's blood pressure. So here's what happens, Simi. Your berry aneurysm has a fixed rate of rupturing based on its size. Its size is not related to hypertension. It ruptures. There we go. There's our bark. It ruptures. So Simi, what happens? When it's now open and gushing, acute cerebrorenal ischemia drives further rises in blood pressure. And the hematoma that the patient has now increases more and more and more. So the patient's hypertension is making the problem worse because now there's a wide open blood vessel in the brain that is bleeding much more because the patient's hypertensive. If the patient wasn't hypertensive for any other reason, hypothetically, then would the bleeding have not happened in the first place? No. It would have happened, but it wouldn't be that bad. But what gets taught to all of us really is that the hypertension is the entire culprit for that entire event, but when it is a mere contributor. And if hypertension were the entire culprit for the entire event, and if that logic were true, then simply controlling the blood pressure would fix the whole problem. But you tell a patient who just had a ruptured subarachnoid hemorrhage that if their blood pressure is 140/70, they're going to be fine. Don't worry about it. No. Their other berry aneurysm is going to rupture at the exact same rate as it would have independent of the blood pressure. So if you really ask yourself, what are the complications of acute hypertension? Acute hypertension really has no complications, except it takes advantage of cardiovascular vulnerability. And there are fragile points in the cardiovascular system that are living on the edge. And if they were to have an independent event, those cardiovascular features would be further compounded by a rise in blood pressure. So you really, in somebody with if somebody has acute hypertension and develops a problem, the problem is often one in which the patient is living on the edge cardiovascularly and then tips over to an acute crisis. Now, there's one exception to that, and that exception is the heart. And you may have an extremely vulnerable heart that cannot handle any rise in blood pressure. And that's because the heart is very, very stiff and often ischemic. And so the major direct complication of acute hypertension occurs in a specific population of people whose hearts are no longer able to pump against high pressure. And it's a vicious cycle, because the most common reason why hearts lose their ability to pump under high pressure is from chronic undertreated hypertension. And they get really bad LVH. And they also get small vessel disease in their heart, not in the epicardial coronaries, unless they have other things, but their heart gets ischemic. And so you have this vicious cycle where now the heart is only able to effectively pump against a relatively normal blood pressure. And if the blood pressure surges, the heart can no longer push things forward, and it pushes things backwards. So the major complication of acute hypertension that is independent of another event is flash pulmonary edema. Everything else requires another inciting event. So if your aorta ruptures, for example, now hypertension isn't a good thing for a ruptured aorta, but the risk of that aorta rupturing or dissecting is an independent event related to other variables. Now that you've had acute cerebrorenal ischemia, your aldosterone skyrockets because your kidneys or your brain are underperfused. And now the process is a worsening vicious cycle. So hopefully those two examples help reinforce the point that whenever you have hypertension, acutely so, it's almost always acute on chronic disease. The causes of hypertension probably should be divided into chronic and acute. Chronic hypertension you usually don't know. But if you're trying to understand why this unique patient who's either young or refractory to treatment has hypertension, you will find the answer in either them having too much aldosterone, too much catecholamine, or rarely diffuse endocrinopathy like acromegaly or thyroid disease. Acute hypertension is a very limited differential diagnosis, with the idea being that it's just catecholamines or just acute cerebrorenal ischemia. More often, we're really fixated on why this patient with chronic, not why this patient with acute on chronic hypertension, they're here in front of us and they look fine. What's going to happen to them today or tomorrow? And the vast, vast, vast majority of complications of hypertension are chronic, long-standing remodeling of the cardiovascular system. The only direct complication of acute hypertension attributable solely to the blood pressure is flash pulmonary edema. So here's the beautiful thing about flash pulmonary edema. It's not subtle. So if you have a well-appearing patient in front of you with the highest blood pressure in the world, but they're well, what should you worry about before you know they're well? You should worry about, wow, they have an acute hypertension. I haven't met them yet. Acute hypertension can be caused by a catecholamine surge or acute cerebral renal ischemia. What they could have is ischemia to the brain, ischemia to the kidney. The other category of causes of acute hypertension are anything that causes a catecholamine surge, i.e. anything that is sudden, a sudden blockage, a sudden rupture, a sudden discharge of electroactivity, a sudden action of a specific molecule. Look at that list. It's overwhelming. And there's one other complication you have to track. That's not the cause of the acute hypertension. It's the fully attributable complication, which is flash pulmonary edema. So you're thinking about this blood pressure being 230/110, and you're thinking about all these things. Sympathetic surge from sudden onset, acute cerebral renal ischemia, or flash pulmonary edema. And you walk into the room and the patient says, "Hi, doctor. I measured my blood pressure this morning with my blood pressure cuff at home, and it is 210/110. And so I'm here. What's wrong with me?" And you're like, "I'm going to cry because I thought about all these horrible, life-threatening things. And this patient looks so fantastic." If the blood pressure is going through the roof, the patient's clinical syndrome should also be going through the roof. And if you find a disconnect between those two things, what is happening? Either you're actually just seeing chronic undertreated hypertension, or that you have the most common cause of an acute catecholaminergic surge, which is the patient either anxious, uncomfortable, the very, very benign diagnosis of exclusion that we have in that sympathetic excess schema. So just remember this: somebody's really, really hypertensive and they have a clinical syndrome attributable either as an underlying cause or as the one consequence, they should be just as sick. And if you notice that disconnect between the blood pressure and them, they probably either miss their medication or you need to sit with them for a little while and explore what's making them uncomfortable mentally or physically. What usually happens? Gosh, none of those things usually happen. Usually patients get EKG and troponin and and this and that. That isn't just ineffective use of resources. It actually compounds the underlying issue. Because now, guess what? You're training the patient to panic every time their blood pressure is 170/110. So I will end and then open up to questions by telling you what my mentor and office mate teaches patients who come in as described. He says, "Oh, so nice to meet you today. I'm so glad we had this talk where we disconnected your concern about the blood pressure with your symptoms. Now, I would like you to go to the Golden Gate Bridge. And on the Golden Gate Bridge, I would like you to take your blood pressure machine and throw it over the ledge. And by the way, be careful. Make sure that it doesn't hit the safety netting, that it has to go over to the to the other side and make it into the water." Of course, he's joking. Blood pressure machines are really important for treating chronic hypertension and medication adherence, but it's a perfect spiel to disconnect the iatrogenesis of overfixation and anxiety that we cause our patients by associating these two things. Yeah. So I'll stop there, and I would love to tap into the clinical experience of two people who are seeing a lot of patients now, Elena and David. So maybe Elena, I'm curious what your reflections and any other experiences you've had, and David the same, before we open it up to questions from everybody.
David, do you want to go first? Yeah, thank you so much, Rabih, for the session, and thank you all for sharing your comments. This this is yeah, one of the topics that really
Sorry, do you mind if I dump it here?
Yeah. Parisa, did you want to say something?
I think she was doing some lab talk. I took care of it.
Oh my God, I'm so sorry.
No, do it again.
Yeah, yeah, where can I start? So I see a lot of patients who are hypertensive, and there's, yeah, as you said, so many reasons why patients can be hypertensive acutely. But it's very hard in the ED to have this conversation because I'm having it like 10 times a day with my attendings and with the nurses, and everybody is like worried when the blood pressure is up. And I think in like I haven't gotten like the full confidence about these patients. And I think I need more experience to like also confidently tell the nurses to like say, hey, it's not a problem. The patient is fine. There is no need to worry about the blood pressure, even if it's like 210 or something like that. And I think I'm actually what I often see is as soon as the patient goes up to the floor, the blood pressure drops by like 50 systolically. So it's all good and it's all fine. And I'm actually even like I'm more worried if they've gotten any kind of medications because I wasn't able to like stand my point. Because usually the cerebral perfusion pressure adapts over time. And most of the patients have had this like blood pressure for weeks, if not months, if not years. And if I now start lowering the blood pressure in the absence of, as you mentioned, like flash pulmonary edema, acute stroke, then I will cause damage to the patient, and not only to the brain, but any other organ too, because the same mechanism applies to any organ. It adapts to the pressure that it's being perfused with. So yeah, this is a really hard topic, but I have to say that the only situation when I do feel confidence about like aggressively lowering the blood pressure is flash pulmonary edema. And any other circumstance, I'm like, how can I convince the people around me to like don't look at the blood pressure and just don't measure it anymore? Yeah.
Yeah, you're compelling me to. We should probably release this as our public academy session. We haven't done one in a while, so we'll do that because I think hopefully it'll resonate with people, or we might get some very powerful counter arguments. I can't wait to read the comments on this one. We might be a little spicy. I'd love to for David to reflect, but I just want to hold the idea that like this is Elena, you're on a journey to hopefully impart change around you, but I think it's been such a deeply entrenched fact that I will share with you that my experience as a trainee was just as yours, just identical to yours, I would say. But now as a 11-year out of training, I will say that now you have the clout that nurses will never come to me and tell me the patient's blood pressure is high. Never, ever, ever. And I have the benefit of working in a closed unit. So they know that I only care if the blood pressure is less than 100. If not, they don't even bother. And so you stay focused on the path you're on. It'll be a long one. It took maybe 6-7 years for me to have the privilege of earning the trust of other people to take that leap of faith with you. And it's easier if you're just working in the same unit with the same people who you consider family. But I finally arrived in blood pressure nirvana where nobody will ever ask for a blood pressure medication. David, I'm curious what your reflections are.
Yeah, nothing pretty much to add. Like I agree with all you said, and yeah, nothing to add except that well, you've also commented this, but another very common situation in the floor also is hypertensive patient that is feeling good, but like you see he's not being hypertensive in the last days, and now he's yeah, hypertensive for 2 separate like shifts or so, and patient is not being just look if he has any urinary retention, that is another common cause, and don't know why sometimes it's not painful. When it's painful, it's very clear, but sometimes it's not, and yeah, it's another common cause. But yeah, agree with all you said.
Yeah, I think it's such an outstanding thing for us to re-emphasize what this whole spiel is about. Is hypertension, acute hypertension can be a marker of disaster happening. Don't overlook that. This is meant to be a reflection on the idea that the disaster should be proportionally impressive when you see the patient as the blood pressure. So that's very real. The second is actually that in jest, we're all saying like how often we get called for high blood pressure in a patient who appears fine. And I think that appearance fine should be caveated is appearance fine compared to what you expect the crisis to be. Ultimately, there is a problem to solve in that moment. And that problem may be that you have an opportunity when you get to know the patient to intervene over a few months on their chronic untreated hypertension, or you're lucky that their blood pressure rise is giving you a clue. They have either some subtle physical or psychological discomfort. And I think it's an opportunity to really address that. And that subtle physical or psychological discomfort may be a game changer if it's urinary retention or constipation, or the patient having suffered all sorts of subtle consequences. But more often than not, it's actually physical and psychological discomfort that we have created by having patients be so obsessed, or patients or colleagues be so obsessed with making that number pretty that when it's not pretty, you trigger a vicious spiral of anxiety on many people's parts. And so my office mate builds a wonderful relationship with the patient, and this spiel about throwing the blood pressure cuff is meant to build rapport. Here's this doctor who's very thoughtful, very kind, very smart, telling you to do this jovial thing. And so it actually is a very powerful tool to address what the core issue is for most of those people. It's anxiety about their blood pressure. And so what's my final takeaway? Acute hypertension, either there's utter catastrophe, it'll be obvious, or there's primary undertreated hypertension, or there's some really subtle, hard to miss potentially physical, psychological discomfort that the patient has. And so I encourage you to not walk away from acute hypertension without doing anything. The answer lies in one of those three places. And in my experience, it's actually usually the latter category. Some physical or psychological discomfort that is often iatrogenic. All right, let's end it with that and see